on here. So good evening, everyone, and bonjour to our board chair, board members, colleagues, and our Indigenous partners joining us this evening. And I see some of our partners that are on, so feel free to turn on your camera if you're interested. So for those I haven't met, my name is Will Bresson. I'm our research and policy advisor, and it's my privilege to be co-presenting with Karina Artuzo, our youth engagement coordinator, who's been deployed to the position of Indigenous liaison during COVID-19. And we're privileged to be joined by some of our First Nation, Métis, and urban Indigenous partners, offering their time to be here with us and to share their reflections from the past 2 years. So some of you may think back to October 2019, when Laurie Zeppa, our Director of Health Promotion and Prevention, presented with Liz, Director of Shinglok Residential School Center at the time, who's here this evening, on Indigenous engagement in Algoma. This may have preceded some of us, but the presentation had spoken to Indigenous peoples in Algoma and engagement efforts from 2014 to 2019, with some vision as to where we were headed together with our partners. And today, Karina and I hope to bring us to speed to 2022. And since that presentation, we've been deeply focused on tackling the COVID-19 pandemic together. Therefore, this presentation really focuses on exactly that, working together, how we've collaborated and built relationships with our Indigenous partners during COVID-19. So as we journey through this presentation, we'll take some time to cover the Ontario Public Health Standards and guidelines that underpin our work in health equity and relationship building with our Indigenous partners. These standards and guidelines are further strengthened by Truth and Reconciliation Commission calls to action that align with public health practice. Understanding that at the core of our work together has been building and strengthening relationships, we'll review principles for mutually beneficial relationship building with Indigenous communities derived from the locally driven collaborative project that was conducted in 2018. This really sets the stage for the who, the what, and the how, where Karina will provide an overview of our Indigenous partners in Algoma, our work together during COVID-19, the actions facilitating our partnership, and the lessons learned, recognizing that the last 2 years have certainly come with their challenges. Finally, we provide an update on our internal work as an organization and as partners committed to reconciliation, before opening the floor to our partners to share their stories and reflections from our work together. This presentation really aims to highlight how we were able to meaningfully involve our local Indigenous communities in COVID-19 response and how we're going to take the strengths and lessons learned to better our work together in COVID-19 recovery. So our public health standards include language that explicitly speaks to engaging with Indigenous communities and organizations. For example, the foundational standard of health equity, requirement number 3, states that engagement with Indigenous communities and organizations, as well as with First Nation communities, striving to reconcile jurisdictional issues, shall include the fostering and creation of meaningful relationships, starting with engagement through collaborative partnerships, in accordance with the Relationship with Indigenous Communities guideline. The guideline provides our Board of Health with fundamentals to begin forming those meaningful relationships with our Indigenous communities that come from a place of trust, mutual respect, understanding, and reciprocity. And the overall goal of the health equity standard is that public health practice results in decreased health inequities so that everyone has equal opportunities for health. We know that COVID-19 has truly highlighted the inequities in healthcare and social determinants of health for structurally marginalized populations, including Indigenous peoples in Algoma. It has also demonstrated the strengths of those same Indigenous people by the way they've continued to support each other and public health during the pandemic. As mainstream public health, fostering Indigenous participation was critical to get through these challenging times and to achieve our shared goals in COVID-19 response and immunization. So it was well understood before the pandemic that across all levels of our agency and government, as Karina will later explain, that we need to develop approaches to respond to the needs of Indigenous people and build relationships to become trusted partners on the journey towards reconciliation. So speaking of reconciliation, the Truth and Reconciliation Commission of Canada defines reconciliation as the ongoing process of establishing and maintaining respectful relationships. A critical part of this process involves repairing damaged trust by making apologies, providing individual and collective reparation, and following through with concrete action that demonstrates real change. Through the Truth and Reconciliation Commission, there are 94 calls to action identified, and 7 specifically focus on health. And these 7 calls to action for health are deeply aligned to public health practice. And we see that through the pieces of closing the health inequities gap experienced by Indigenous people in consultation with Indigenous people, as aligned to the health equity standard and guideline. We see that to address the distinct health needs of urban Indigenous and to recognize the value of Indigenous knowledge and practices and to use them in collaboration with Indigenous partners, while still facilitating cultural competence training for health professionals in public health. So how exactly do we work together to respond to these calls to action and our standards and to build mutually beneficial relationships with our Indigenous partners? We need to apply sound principles and practices for engagement. So in 2017, 5 Northeast public health units received funding for a 2-year locally driven collaborative project, otherwise known as the LCDP project, with First Nation representation to explore the principles and practices for engagement between public health and First Nation to improve community health. In 2018, the LCDP project's Phase 1 literature review identified 4 principles that were foundation for engaging with First Nation communities. These 4 principles and their associated WISE practices or actions for collaboration help to inform the basis of our relationships during COVID-19. So these 4 principles include, first, being respect, which focuses on the need for non-Indigenous people to understand, acknowledge, and appreciate the history and current context of Indigenous people. Cultural competence development is really the precursor to respectful engagement, and later in this presentation, you'll see how we're working on this internally as an agency. WISE practices for enacting this principle include formal acknowledgement practices, such as our land acknowledgement, that identify the traditional owners of this land, and posters or signs in clinical spaces to encourage Indigenous clients' feelings of safety. And you'll see that this was done at our GFL MIC. The next is trust. Trust is recognized as foundational to establishing and maintaining mutually beneficial partnerships and relationships. Historical and ongoing events have contributed to considerable distrust by many Indigenous people, making trust a central element to any effective engagement. WISE practices to develop trust include early engagement, working with respected Indigenous members, such as our partners here tonight, inclusivity of Indigenous members, and appropriate and ongoing communication, something that has been prioritized during COVID, not only by Karina as the liaison, but by Indigenous partners and APH staff at all levels to facilitate working together. This came directly from our MOH and directors to nurses and public health inspectors, being prepared to listen, allow time for discussion, and communicate upfront and honestly about all of the expectations, intentions, resources, and limitations was key to building trust. Third is self-determination. Self-determination acknowledges the inherent rights of Indigenous people to freely determine their own paths and to make decisions. Engagement that is driven by and for Indigenous people yields the most successful partnerships. WISE practices aligned to self-determination include building Indigenous workforce capacity, using a strength-based approach to working with Indigenous communities, and having strong Indigenous representation in decision-making, as you'll see when Karina speaks to our vaccine rollout in First Nation communities. And fourth is commitment. Commitment is needed in order to sustain long-term and effective partnerships. It focuses on the importance of tangible and sustainable actions. Wholesome engagement can be supported by co-learning, power sharing, and being flexible to foster mutual responsibility. Progressive leadership is also needed to do things differently to meet the needs and preferences of each unique community. Commitment is also demonstrated by ongoing reflection, which we hope we're all doing a bit of tonight. These principles are not mutually exclusive, but rather interconnected, with one building on the next. So with respect, you gain trust, and with a high degree of trust, there's more commitment, and a commitment to progress towards self-determination when we work together. As you'll see when Karina shares the how for how we work together, these 4 principles form the foundation of actions that facilitate our relationships and partnership through COVID-19. I'm now going to pass it over to Karina to take us through the who, the what, and the how of the last year of our work together with our Indigenous partners.
Miigwech, Lil. So I am going to start by identifying who our Indigenous partners are. But before I do so, I really want to acknowledge with appreciation those partners who were able to take the time to be here today. So Miigwech, everyone. Okay, so identifying who partners are, I will begin with the 7 First Nation communities aligned with Algoma Public Health for COVID-19. Starting in the north, there is Mishipcotton First Nation and Missinaba Cree First Nation. And we have to note that for Missinaba Cree First Nation, they are positioned differently from other First Nations aligned with Algoma Public Health because their community members reside in urban hubs located in Wawa and Sault Ste. Marie. So this is just something that, in our work together, we've always had to be really mindful of. In Sault Ste. Marie area, there is Batchewana First Nation and Garden River First Nation. In Central and East Algoma, there is Thessalon First Nation and Mississauga First Nation. In the Elliott Lake and area, there is Serpent River First Nation. And I will note that Sagamuk Anishinaabeg is aligned with Public Health Sudbury District for the purposes of COVID-19. Now, the Algoma district is also home to one historic regional rights-bearing Métis community, known collectively as the Huron-Superior Regional Métis Community, which consists of 2 Métis community councils. These councils function to provide a local level of elected representation for the Métis within the Sault Ste. Marie and North Channel areas. So these Métis community councils include the historic Sault Ste. Marie Métis Council, located in the Sault Ste. Marie area subregion, and the North Channel Métis Council, located in the Central and East Algoma subregion, as well as the Elliott Lake and area subregions. The Huron-Superior Regional Métis community is also part of the Métis Nation of Ontario for representation at the provincial level, and the Métis National Council for representation at the national and international levels. It's also important to note that Algoma is home to the landmark Paoli Métis rights case, where the Supreme Court of Canada recognized the Métis people as holding constitutional rights equal to that of other Indigenous peoples. In terms of COVID-19, engagement with Métis partners took place to ensure Métis had a voice in the vaccine planning and access to vaccines in a timely and culturally safe manner throughout Algoma. Alongside partners from First Nation communities and from the Huron-Superior Regional Métis community, there's also the Indian Friendship Center, which advocates for and offers culturally based programs for urban Indigenous community members. These programs span across justice, health, family support, long-term care, healing and wellness, employment and training, education, research, and there's much more as well. So they have a very large portfolio. And when it comes to COVID-19 vaccine rollout and case and contact management, we define urban Indigenous as referring to First Nations who are living outside their First Nations communities, Métis, and Inuit. In addition to the First Nation, Métis, and urban Indigenous communities directly, we are also working with other Indigenous partners. The first partner I want to highlight is Mamwezing North Shore Community Health Services Incorporated. Mamwezing's role is to provide services on an outreach and collaborative basis to 11 First Nation communities and the Indian Friendship Center in Sault Ste. Marie. 6 of the First Nation communities are aligned with Algoma Public Health, and 5 are aligned with Public Health Sudbury District. I also want to highlight, the Bowading Family Health Clinic, which is part of Mamwezing. They provide culturally grounded care for urban Indigenous patients residing in Sault Ste. Marie, noting that they also have some non-Aboriginal patients as well. Similar to Mamwezing, there is the Mushkegowuk Tribal Council, which is the senior representative for 7 First Nations in the Western James Bay and Hudson's Bay, which include Missinaba Cree First Nation. So the Mushkegowuk Tribal Council serves a similar role for Missinaba Cree First Nation as Mamwezing serves for the First Nations aligned with them. The Métis Nation of Ontario Healing and Wellness Branch facilitates and coordinates programs to address the holistic needs of Métis people in Ontario at the provincial, regional, and local levels. And an organization that we did not have a lot of interaction with, but we did make connection, was the Tunga Suvingat Inuit, which offers urban Inuit specific community supports. Now, it's important to note that the Inuit population in Algoma is very small. However, we recognize the commitment needed to address Algoma's off-reserve Indigenous populations, which include Inuit. As public health, we strive to do our best to be aware of the services available for the populations we serve, and we connect when appropriate and always work toward cultural competency. And so now that we've done a brief overview of who our partners have been and are, the next part of this presentation is a high-level snapshot of what we have done together thus far. And I'm going to be focusing on the spheres shown in this slide. So to the left, we have the COVID-19 response, which includes protection, testing, case and contact management. And then to the right, we have the COVID-19 immunization response, which includes Indigenous-led clinics and mass immunization clinics. Now, before I continue, I want to note that even though I am providing a very general snapshot, it's important to emphasize that each community's approach to COVID-19 has been different based on their needs, preferences, and resources. Each Indigenous community is situated differently and is unique. And as such, their experience through COVID-19 has also been unique. And this is something we need to be respectful of in our work together. So let's dive into the what for what we've done together, starting with the COVID-19 response. When it comes to the protective measures of the COVID-19 response, First Nation communities developed pandemic plans for their communities, similar to Public Health's plan for Algoma. Chief and council, with the consult of their, chief and councils, with the consult of their communities in relation to the local COVID-19 context and public health guidance, implemented self-determined measures to mitigate risk at the community level. So things like community lockdowns, facility closures, or a slowed reopening. So when the province was moving ahead, and if communities were not there yet and not comfortable yet, they slowed and did their own reopening when they were comfortable to do so. When it comes to testing, First Nation communities and urban Indigenous partners conducted COVID-19 testing with the knowledge sharing support of Momwazine, Sueria Hospital, and Public Health. Partners reported positive test results to public health via a collaboratively developed positive test reporting form for communication, and I'll speak more to this piece later. So when it comes to the case and contact management part of the COVID-19 response, again, it's important to note that each First Nations approach was different and varied throughout the pandemic. So it was based on factors like timing and number of cases, local First Nation capacity, Algoma Public Health's capacity, and of course, the ever-changing public health guidance. One constant has been that Indigenous peoples are a priority population. So in Algoma, this has meant that cases have been kept locally for follow-up as opposed to being sent to the provincial workforce. This was identified as important to maximize First Nations access and control to their community case information in a timely manner, or at least as best as possible given the realities of this pandemic. And for me, this really demonstrates our ID team's commitment, because even though their capacity was being stretched at different points, which is an understatement, they were determined to keep managing cases locally for as long as humanly possible. And all the while, our First Nation partners were equally committed with their stretched resources, again, an understatement, to keep giving their fullest selves to keep their community members as safe as possible. I'd like to note that public health nurses and First Nation community health nurses worked closely to share case and contact management guidance, updates on local community cases and contacts, and ensure community members who were affected by COVID-19 were as supported as possible. Also, our public health inspectors have been instrumental in supporting facilities and liaising with the First Nation Inuit Health Branch's Environmental Public Health Officer. When it comes to the immunization response, I want to first highlight the Indigenous partner-led clinics supported by public health. These include the First Nations community clinics, Buwading Family Health Team clinics, mom raising clinics held at the Indian Friendship Center. And these were really important because they're all important, but a key feature here is that they leverage trusted relationships with clients to immunize some of the most vulnerable and hard to reach clients. Partners vaccinated community members aged 5 and up and those most vulnerable. So people from elder lodges, congregate living settings, unsheltered populations, people with addictions and mental health challenges, children in care. And also APH maintained a public health nurse aligned to each community for support. And a stat that I would like to highlight is from January 1st to January 31st, 248 Indigenous-led COVID-19 vaccine clinics were hosted with over 14,000 doses administered. When it comes to the mass immunization clinics across Algoma, Métis and urban Indigenous partners were involved in the onset of clinic planning to help create a more inclusive and welcoming space for all. Some culture-based supports included an opening ceremony held by M&O partners on site at GFL and was inclusive of all clinics that would be taking place throughout Algoma. There was an offering of thanks, a pipe ceremony, and historic Sault Ste. Marie Senator Powley offered a prayer for healing and wellness. I would like to acknowledge the GFL partners as well for ensuring there were no structural or systemic barriers to offering and to holding this ceremony. The M&O also created a series of culture-based posters that were distributed throughout MICs. And First Nations healthcare workers helped staff some of the MICs. So again, there is a lot of support to maximize efficiencies as best as possible and work towards a culturally safer space. So in the last 5 slides, I shared a high-level summary of what work was done together. But what is most important is how we did this work together. Our approach has aimed to be collaborative and Indigenous partner-led. 4 actions supported this approach, which include the integration of local community context, timely, transparent, and ongoing communication, regular opportunities to gather and engage at all levels, mutual support for expanding and building capacity. These actions facilitated our relationship building. They were carried out by our Indigenous partners, as well as by our APH staff from different programs and leadership. They serve to help us work toward our shared goals. These actions are actually wise practices that align with the 4 principles of respect, trust, self-determination, and commitment. And in the next few slides, I'll speak to each of these actions more specifically with some brief examples. So when we look at the integration of the local community context, Dr. Liu really encouraged an approach that invited early engagement and consultations that identified First Nation, Métis, and urban Indigenous needs, preferences, and capacities alongside our own public health mandates, the ever-changing provincial guidance, and our organization's capacity. To summarize examples of what this looked like on the ground, we involved Indigenous partners in vaccine planning early on in the process. With partners, we assessed communities' needs, preferences, strengths, and lessons learned together. We followed the lead of Indigenous communities. With partners, we clarified and redefined the roles and responsibilities of communities, public health, and the First Nation Inuit Health Branch based on communities' approach to COVID-19. And there was the facilitated knowledge sharing to help inform local decisions concerning community lockdowns, vaccine rollout prioritization, communication needs. And it's here I really need to emphasize the tremendous leadership of Mom Raising throughout the pandemic, which has been foundational to all of the work that has been happening as they bring together all of the partners aligned with them, including Algoma Public Health, and create opportunities for knowledge sharing and collaboration. So I want to share in two examples where the effectiveness of this approach can be demonstrated. And the first is about the informed decision-making process for First Nations around the onboarding of COVAX. So for those who don't know, COVAX is an electronic record system that houses vaccine-related information in terms of inventory, dose tracking, documentation of doses administered. For me, there was a big learning curve around COVAX and the application of First Nations data principles of ownership, control, access, and possession, known as OCAP principles. These principles assert that First Nations must have control over data collection processes and that they own and control how this information can be used. Now, this all seems like common sense, but in Canada, there's a long colonial history of, quote, research on Indigenous peoples that has caused harm, to say the very least. And that data was used for other purposes without permission at the expense of Indigenous people to the benefit of non-Indigenous people. So you can see the importance of establishing OCAP principles and their value. So previously I understood OCAP principles in the context of research, but I wasn't sure about the application to COVAX. So I started out by doing my own homework, and then I consulted with Mamwezian's NP, Richard Cartier, for support. I transparently shared all of the information I knew and all of the information I did not know. And he shared his knowledge and had some follow-up questions about COVAX. So then I took his questions back to the team, and Christina Luukkonen found the answers for us. And then, after Richard was equipped with all of the answers to his questions, he made the decision to support COVAX from his Mamwezian role and perspective. I then repeated this process with each individual community partner. Ultimately, it turned out that all community partners chose to be onboarded. And it was a lot of work up front, but everyone went the extra mile. And no one could have predicted the vaccine mandates that would come and how helpful COVAX would be to that end. So the initial decision of partners to be onboarded ultimately saved a lot of time and extra challenges in the end. Now, let me be clear. If partners had chosen otherwise, we would have supported them in doing so. And then whatever came our way, we would problem solve through the challenges together. The key in this example is sharing all of the information that we know and all of the information that we don't know, and that we're answering questions for partners to make their own informed decisions. The second example I would like to share is how First Nation communities determine their own highest risk and prioritization for COVID-19 vaccine distribution, and how this varied from community to community based on their unique situations. So First Nations and urban Indigenous partners use public health guidance and the Indigenous Primary Healthcare Vaccine Toolkit, as well as their own expertise of their community, to prioritize vaccine distribution when supply was very limited. There was a point in the pandemic when the Ministry of Indigenous Affairs announced a prioritization that conflicted with that of some of the First Nation communities, like Garden River First Nation and Batchewana First Nation. Batchewana First Nation and Garden River First Nation shared the painful realities of what this provincially imposed prioritization looked like on the ground, and how it was not serving the safety of their communities as intended, and it was causing harm. And so a lot of times this happens. Policies at the upper levels, well-intentioned, don't necessarily understand there are some unintentional consequences that happen as a result. And so this was brought to Dr. Liu's attention, and she was able to invoke local flexibility in this case to reinstate Indigenous-led prioritization. The second action that facilitated our work together was the importance of timely and transparent communication. This included the sharing of new guidance and directions, the upfront and honest communication about government, agency, and/or community expectations, intentions, resources, and limitations, ongoing and non-time limited communication. And even during the busiest of surges during COVID-19, public health staff were committed to offer their fullest selves as did our Indigenous partners. There was also the open sharing of community needs, preferences, and challenges as they arose. As Indigenous liaison, it was really important for me to ensure that we can have even the most difficult of conversations. My hope is that I could be open and trustworthy enough that partners are able to share things that are not working out, that we could put anything out there and everything out there, the good, the bad, and the ugly, and that we could work through it all together to problem solve and strategize solutions. As a liaison, I feel confident to be this way because I feel supported that our organization is developing a strong internal capacity to respectfully address our partners' concerns in a meaningful way. And every time, like as a public health unit, every time this can be done in good faith, this supports a much deeper relationship as we move forward together in different roles in public health in the spirit of reconciliation. And so here are some examples of what this looked like more concretely. Everyone was readily available by phone or email for questions and idea sharing. So this includes First Nation, Métis, and Urban Indigenous partners, myself, and various public health points of contact, like the Medical Officer of Health, our infectious disease team, our immunization team, our healthy workplaces team, our public health inspectors, as examples. Communities shared tools for forecasting resource supply and use. And weekly to daily e-blasts were sent to all partners to share updates as received by public health on COVID-19 guidance, IPAC, testing, vaccine rollout, vaccine workplace policy development, and all of this at the local, provincial, and national levels. There was a development of reporting and communications forms for COVID-19 test results. And there is a development of shared case management process map and resources to clarify the roles and responsibilities for FNIB, the First Nations Inuit Health Branch, Algoma Public Health, and First Nation communities. So here I'd like to highlight that the initial process was started by Garden River First Nation with FNIB and APH to address challenges that they were experiencing early on in the pandemic. And once Garden River First Nation had a process that was working for them, then we worked with all of the First Nation partners and consulted to continue to modify it until we had a process that worked for everyone. The process map and resources outline how we work together, clarifying roles, responsibilities, processes, and practice standards. This is like a living document that we can continue to adapt together as needed. This shared process is essentially a positive outcome of the challenges we have overcome together and help make things smoother moving forward. Examples of communication with communities. Indigenous partners developed and shared key messages for their respective communities. Partners shared resources for COVID-19 that could be adapted and amplified. We created an Indigenous health and COVID-19 webpage that shared Indigenous-led culture-based resources. Our communications team provided ongoing support as needed, attended the Mamwazing communications meetings, provided news releases upon request, amplified Indigenous partner messaging, advertised partner clinics when requested, provided key messaging that could be adapted when needed. So in these examples, we really see a demonstration of trust and respect with collective knowledge sharing and communications. The third factor that facilitated our work together was the opportunity to gather and engage at all levels. It is here where I really need to highlight Mamwazing's leadership with the coordination of the COVID-19 task group and sub-working group meetings. These meetings were established to bring Indigenous understanding, expertise, and leadership to the forefront of planning. They serve to connect First Nations communities, public health units, Red Cross, Ontario Health, Indigenous Services Canada, and other partners for knowledge sharing and relationship building. They ensure a response that is specific to the unique local context and needs, and as we had talked about how important that is. And they focused on enhancing communication between all parties involved. From an APH perspective, there were several types of meetings that took place to ensure our Indigenous partners were connected with with additional health sector partners throughout Algoma, and that communication continued. So for example, there's the weekly to bi-weekly APH-led vaccine partner subregion meetings, which provided the opportunity for partners to connect with local public health and share community updates and needs arising. These subregion meetings had the involvement by Indigenous health sector, primary care, long-term care, hospitals, pharmacies, and municipal partners. Also, as needed, one-to-one meetings took place with communities and our Algoma Public Health team. So things like during vaccine clinic planning, case and contact management, these kinds of examples. And a lot of these were impromptu and yeah. So the fourth strength of our relationship and partnership included mutual support for expanding capacity during the pandemic. This mutual support included the organic sharing of staff and resources as needed, continuous knowledge sharing and learning from each other, First Nations communities providing various client supports, so isolation kits and essential goods, beyond those that were accessible by local public health. And here are some brief examples. So First Nation communities work collaboratively with each other and with APH to minimize vaccine wastage. First Nations help staff vaccine clinics when needed. And the HR capacity for First Nations communities is extremely limited, which has been exacerbated by COVID-19. So Indigenous partners identified the need for extra time for preparations whenever possible. Now, of course, sometimes the realities of this pandemic did not make that possible, but even in those situations, we worked collectively to problem solve. So for example, at the start of the vaccine rollout, there was an opportunity to get the vaccine before the COVAX training was possible for Serpent River First Nation. And so what happened was the aligned public health nurse openly and transparently shared all of the information with the health director and team, and then they determined how they wanted to proceed. When they indicated they wanted to proceed at the earliest possible delivery time, the Serpent River First Nation team worked extra hours to do all of the preparations that they needed to do on their end. And also the public health nurse put in the extra time that was needed to deal with COVAX and then the public health arrangements on her end. As noted previously, each First Nations approach to case and contact management varied throughout the pandemic based on the timing and number of cases, local First Nation capacity, public health guidelines, and APH capacity. So here's some examples of how that worked. So originally, Batchewana First Nation and Garden River First Nation preferred Algoma Public Health to take the lead due to limited HR capacity, and that they would provide the support as needed. As APH capacity became strained in different parts of the pandemic, the community health nurses took on the contact role and APH maintained the cases. With the Omicron surge and the provincial change in case management guidance, community health nurses for all of the communities and the Indian Friendship Center have been providing currently providing case and contact management at the point of testing, which is really the most efficient way to do it, and also the best way to ensure that clients are reached. Sometimes when you have follow-up phone calls and that kind of thing, it's harder to reach versus being right there when the test results are there. So APH's role is to support as needed and is focused on the highest risk settings like elder lodges and congregate care settings. I will note that Serpent River First Nation conducted all of their own case and contact management from the start and maintained this approach throughout all of the waves. Some communities, like Mississauga First Nation, did not have any cases until the Omicron surge, which for them presented different challenges that needed to be worked through. So I just shared 4 actions that facilitated our relationship building in collaboration during COVID-19. Next, I want to highlight some of the challenges and lessons learned. So it goes without saying that our partnerships throughout COVID-19 did not go without challenges. There is much room for reflection and growth to facilitate more meaningful and strong relationships that will see us through future pandemics and addressing other public health priorities. So the following challenges and lessons learned were identified during our fall pandemic planning discussions that took place through Mamwezian's working group meetings. And here are some of the key learnings that were highlighted. Communication between agencies and levels of government takes time and can hinder rapid community level action. A coordinator or a liaison at the community level and in public health are essential. Pandemic plans exist for each First Nation community and could be shared more broadly to allow for public health input and pairing with district-wide plans. The pandemic response stretched human resources and highlighted training needs, reinforcing the need for mutual support when the health sector capacity limits are reached. And the rapidly changing and misaligned directions between provincial and federal guidance meant that prioritizing local needs and preferences was essential, yet at times very challenging. For example, Indigenous partners went above and beyond to support implementation and make guidance fit using a strengths-based approach and sorting through nuances and complexities, requiring challenging conversations between partners. Routinely scheduled one-to-one touch points between First Nation communities and APH would be valuable for more detailed community level sharing. And the need to streamline communication between channels and agencies to avoid information overload. And finally, the need for colleague-to-colleague mental health support during crises beyond routine meetings. So opportunities that you could be built in for debrief and sharing and peer-to-peer support. However, above all, we've learned that through the 4 principles for engagement, that we have accomplished more together than we could have accomplished alone during COVID-19. To nurture and sustain our relationships, a process of continued reflection will be needed to ensure opportunities remain meaningful and all involved are equally respected and benefiting. This process of reflection will happen collectively, but we also need to do so internally as we work towards reconciliation. So where did our internal work take us? Here, I would like to highlight the work of the Indigenous Engagement Working Group. And although a lot of this work has been paused during the pandemic, in 2021, there was a need for us to come back together and to acknowledge and reflect on the recovery of the children's remains and unmarked graves. So through the Indigenous Engagement Working Group in 2021, there were 3 Indigenous Engagement Working Group meetings that were held to bring leadership and staff together for reflection, learning, and planning meaningful organization-wide action. 2 Indigenous engagement awareness newsletters were developed to share resources, Indigenous-led events and dates of significance, and learning opportunities with staff. 10 reflective practice sessions and 1 debrief session was led by our very own public health nurse, Ingrid Akomiak, who identifies as Inuit from the Nunavik region, but currently lives in the Nunavik region, but lives in Elliott Lake. The agency-wide reflection of July 1st with respect for the recovery of children's remains and unmarked graves. The revision and renewal of our land acknowledgement on September 22nd, as was presented to the Board of Health. Agency-wide recognition of Orange Shirt Day on September 30th, in which orange shirts were provided to all staff and Board of Health members to wear in solidarity with Indigenous families, along with an Indigenous Engagement Working Group newsletter and memo that was shared on the staff portal, and an email that was sent to all staff by Dr. Liu. Within the land acknowledgement briefing note that was brought to the Board of Health, we committed to the internal work to support cultural safety education for all staff through virtual learning webinars, lived experience sharing, ongoing reflection, and the integration of learning and reflection into public health practice. As mentioned in our Algoma-wide land acknowledgement, we remain committed to the shared goal of reconciliation. Through our COVID-19 response, we have built and strengthened relationships to support our communities using a health equity approach. This work does not stop here, nor when the pandemic ends. In order for these relationships to continue growing and our communities to continue becoming healthier, we are going to need to take even more action in the months and years to come. So from a high level, what does this mean and what does this look like? Building on our work together thus far, we are going to journey forward to address the calls to action and reduce health inequities affecting the health of Indigenous peoples in Algoma. This means collectively, we will reflect, assess, and strengthen our partnerships by focusing on the 4 key principles to support Indigenous health and well-being and reduce health inequities. Identify ways to sustain meaningful and resilient partnerships beyond COVID-19. Explore community needs and shared priorities for program level action with Indigenous partners. So for example, mental health, substance misuse, drug strategy, climate change, emergency management planning, to name a few. Renew service agreements such as that with Garden River First Nation that has been in place for over 20 years and commit to further opportunities for working together. Share knowledge and learn from Indigenous partners to develop culturally safer ways to support community health and well-being. Build internal capacity and understanding of Indigenous history, presence, and rights, that we value and respect Indigenous ways of knowing, being, and doing as we work towards true reconciliation.